Okay, great. So I think we'll get started. Hi, everyone. Thank you so much for joining us today for LARVOL's live discussion on the top abstracts coming out of ASCO GU. My name is Kanisha Gala, and I'm a project owner at LARVOL. I will start us off today by introducing our wonderful panel. So today's moderator is Dr. Tian Zhang. She is an assistant professor of medicine and a member of the Duke Cancer Institute at Duke University. Our panelists are Dr. Neeraj Agarwal, Petros Grivas, and Shilpa Gupta. Dr. Agarwal is the director of the GU program, the director of the Center of Investigational Therapeutics, and a lead in experimental therapeutics at the Huntsman Cancer Center at the University of Utah. Dr. Grivas is a clinical director of the GU Cancers program and an associate professor of medicine at the Fred Hutchinson Cancer Research Center at the University of Washington. And Dr. Gupta is a member of the GU Malignancies program at the Case Comprehensive Cancer Center and an associate professor at Cleveland Clinic. So in today's webinar, we'll be discussing 5 abstracts that were selected due to their potential clinical impact. And we have specifically asked our panelists to comment on how these top abstracts will affect standard of care in GU oncology. And with that, I will hand over the reins to Dr. Zhang. Thank you so much again, everyone. We're really looking forward to this discussion.
Great, thank you, Kanisha. A warm welcome to everyone, and I'm so excited to spend the next hour with all of you and with our friends, Drs. Agarwal, Grivas, and Gupta, in discussing these 5 abstracts that have been selected. Without further ado, I think we'll go ahead and get started with the first abstract. We'll go in prostate, bladder, and then renal order. So this is just the one slide highlighting ACEs. So Dr. Agarwal, would you like to kick us off, please?
Of course. It's a pleasure to be here. Thanks for the invitation and nice to see you all. So this is as we know, this is a trial in first-line castrate-resistant metastatic prostate cancer, and patient could not have received intensified hormonal therapy, which is the current standard now, or docetaxel chemotherapy. This was conducted in, as I said, first-line CRPC setting. Patients were randomized, more than 900 patients were randomized to abiraterone plus apalutamide versus abiraterone alone. The radiographic progression-free survival, which was the primary endpoint, was met. It was improved by almost 6 months. And then when there was updated analysis, which was further improved by 7 months. So on a base of approximately 15 months, which was the standard from the Cougar 302 trial, when abiraterone was tested by itself, on that base of 15 months, radiographic progression-free survival, which was investigator assessed, was improved by 7 months. Intriguingly and very perplexingly, we do not see any overall survival benefit. There are some other clinically meaningful endpoints, which I'd just like to summarize really quick. Time to pain progression, opioid use, like how much time it took for patients to start using opioids for pain in castrate-resistant setting, time to chemotherapy, time to subsequent cancer therapy, were not different in both arms. So here we have a trial, a pretty large trial of abiraterone versus abiraterone with apalutamide, which is there are 2 androgen signaling inhibitors together. And we see a radiographic progression-free survival being met significantly, but we do not see any other parameters being met. That's my summary. Thank you very much.
That's perfect. Thank you, Dr. Agarwal. We'd love to hear from our other panelists in terms of thinking about this trial of abiraterone with apalutamide, the combination versus abiraterone alone. Dr. Gupta, can you comment on how practice changing this set of data are for you, and does it change what you'll do in your clinics?
Thanks, Dr. Zhang. So I don't think this data is compelling enough for me to change my current practice without seeing a definite overall survival advantage. The data does look promising, but we know that a prior alliance trial combining abiraterone and enzalutamide did not result in overall survival advantage. So I would like to see more long-term data. And currently, this wouldn't change my practice.
That's really helpful. And Dr. Grivas, any challenges that you would think of for the combination, or any prescribing difficulties or toxicities that you wanted to talk about the combination?
Thank you, Dr. Zhang, and I agree with Dr. Agarwal and Dr. Gupta. This trial is very important. Congratulations to the investigators and the great presentation. However, these data definitely are not going to change my practice. I think Dr. Agarwal Dr. Gupta discussed that. Number one, there was no overall survival benefit. And to get to your question, there's of course considerations regarding access to care and also copay issues. So when it comes to orally available agents in prostate cancer, and we all have examples of patients who have very high copays, and it's also the issue of physical toxicity that is slightly higher with the combination, and also cost and financial toxicity. And I think that's another consideration that aligns with what has been said, and also another factor that this data, despite showing promising PFS benefit, it is not going to change a practice in the context of no overall survival benefit and also the challenges we just discussed.
That's really helpful. Thank you so much. I certainly also agree with all of you. I think that we really want to see overall survival benefit in this setting, and this study really confirms for us what we saw in the Alliance study of the combination not having additive benefit. Dr. Agarwal, I'll circle back with you, and just one last comment from you about will this change what you will do next week for your patients?
No.
Short and sweet. Very good. All right. I think for time purposes, we'll move on to the next exciting abstract. Kanisha, next slide, please. Dr. Grivas, can you give us an overview about the EV301 trial that was reported yesterday by Dr. Pauls?
Absolutely. Professor Pauls did a great job at the GU ASCO meeting, showing the design and the results of this exciting EV301 trial. This is a randomized phase 3 trial in patients with refractory advanced urothelial cancer treated with prior platinum-based chemotherapy and also immune checkpoint inhibitor. 87% of patients, they were in the third line space, and 30%, in further salvage therapy, so more than 3 lines of therapy. Patients were randomized to either enfortumab vedotin, an antibody drug conjugate against Nectin-4 linked to the MMAE toxin, compared to physician choice of chemotherapy, either single agent taxane in the US or vinflurin in Europe. And the primary endpoint of this randomized phase 3 trial was overall survival, with many secondary endpoints. This trial was built based on the very promising results and high overall response rate and complete response rate in the phase 2 EV201 trial with single agent enfortumab vedotin. As we see in that slide, the phase 3 EV301 confirmatory trial did show significant overall survival benefit with enfortumab vedotin. Median overall survival, as you see, is approaching 13 months. And chemotherapy is about 9 months with a hazard ratio of 0.70. And this was also corroborated by significant PFS benefit with a hazard ratio of 0.61, favoring enfortumab vedotin, which already has an accelerated approval in this setting. And again, this trial, I think it's confirmatory of the significant benefit that this agent can provide in these treated patients. There was some very good discussion at the ASCO GU by Dr. Shiv Karatke regarding toxicity with this agent, and that requires some close attention in terms of patient and provider education, as well as potential hold or reduction of dose, and we can discuss that in more detail. But based on the totality of data, definitely very, very important, one of the most important highlights for bladder cancer, urothelial cancer in ASCO GU.
Thanks, Dr. Grivas. I agree. Certainly came out also concurrent publication in the New England Journal yesterday. That's perfect. And I do want to focus a tinge on the trial design. Dr. Agarwal, can you help us dissect this trial design a little bit more? What do you think are advantages or disadvantages of testing EV in this refractory space against chemotherapy of choice?
So first of all, this is even with EV, this is a patient population with huge unmet need. We just published a study of collating. I think it's a very meaningful study in my view, or report in my view, we looked at the number of patients in the United States receiving first-line chemotherapy or first-line systemic therapy for metastatic urothelial carcinoma, regardless of where they are in the US, what kind of insurance they have. We just looked at all the studies looking at this and basically collated the data. Out of 100 patients diagnosed to have metastatic urothelial carcinoma, only 49 or 48, less than half, receive any therapy at all. And then you go to second line setting, the number drops to 17. You go to third line setting, it goes to 6% of total patients who are diagnosed to have metastatic urothelial carcinoma. So first of all, this is a frail, so what these data tell us, and Dr. Grivas was on the paper with me, and had the privilege of doing it with Dr. Montipal, Dr. Grivas, and Dr. Swami. What those data tell us, they tell us that this is a patient population, as I said, with huge unmet need, frail patient population, attrition rate is very high, and whatever we can do, we should to get these kind of highly well-tolerated, targeted therapies to our patients. So maybe I'm being a little philosophical right now, looking at these magnificent data in this patient population, clearly showing improvement in responses, improvement in PFS, improvement in overall survival. And I think this is the new standard of care, no doubt.
That's a great, context for all of us to think about this very frail population, this population with unmet need that don't actually see a lot of active treatments. So thank you very much for that. Dr. Gupta, I want to turn to you for a moment and ask you a bit about the challenges that you think we're going to face as we try to prescribe enfortumab vedotin and use it for our patients with refractory urothelial cancer. And what do you think some of the highlights of thinking about through toxicities would be as you're educating your next patient about EV toxicities?
Yeah, I would first of all echo what Dr. Grivas and Dr. Agarwal mentioned. This population is a huge unmet need, and we need drugs like this, which show us an amazing response in these heavily pretreated patients. I think the challenge with EV in terms of toxicity that we most frequently see is peripheral neuropathy, which especially these patients who had prior platinums can experience. And the drug needs to be carefully given with dose modifications or dose reductions. So that is one challenge that we see. And Dr. Shilpa Gupta put together yesterday a very good presentation outlining possible mechanisms of toxicity as well. I think we need to be more proactive with adverse events management and make sure we can maximize the benefits of this drug by modifying the doses so patients can leverage the benefits of this agent. Very promising data which confirms the use of this drug already in practice.
Sure. So, just from personal experience, we've had some toxicities of patients treated with enfortumab vedotin, with skin toxicities, with rashes, and also with peripheral neuropathies. And particularly, I think in this population that's pretty refractory to platinum-based chemotherapies, they're already dealing with baseline neuropathies. And so certainly paying attention to that as we get them started on treatment and modifying your doses accordingly would be very helpful. Excellent. So Dr. Grivas, I want to just end with you, and can you tell us, kind of more conclusions, and will this change what you do for your patients next week in this refractory setting?
Thank you, Dr. Zhang. Great comments by everybody. I definitely think this trial is a positive phase 3 randomized trial with overall survival benefit. It definitely informs clinical practice. In my humble opinion, this can let the states for regulatory full approval. There's already accelerated approval, so we use a drug, but definitely there is higher level of evidence to use enfortumab vedotin in the third line space. And I also want to echo what my colleague said about, better education for providers and patients about the toxicity, best supportive care, potential dose holds and reductions if needed. It's great to see new drugs approved in this disease, and I also want to emphasize the need for continuous trials, and there are other agents being tested in this disease. other antibody drug conjugates. Dr. Agarwal and me are working on another one called sacituzumab govitecan, and there is a phase 3 trial called Tropic-04 that is actually close to the design of EV301. So very important data, practice changing, and also exciting other agents in the field. Urothelial cancer is moving along.
It's a great summary. And actually, just to go along with that, Dr. Grivas, I believe enfortumab vedotin is being tested in earlier disease settings. Can you just summarize some of the ongoing trials? Because I think this is pretty important in thinking about the role enfortumab vedotin has in future disease aspects of treating earlier stages of disease.
Absolutely. I will try to summarize briefly here. There is definitely very exciting data. The EV201 study had 2 cohorts, and cohort 1 showed the very promising overall response rate of 44% and supported the phase 3 EV301 trial that we just discussed. The cohort 2 of the EV201 trial, the data were presented by Dr. Balar also at this meeting, very exciting data. This is second line in patients who never received platinum-based chemotherapy for advanced disease, but received checkpoint inhibitor in the front line, and they got enfortumab vedotin monotherapy second line, and they had a 52% overall response rate with a 20% complete response rate as second line after checkpoint inhibitor in a population of 89 patients who were not fit for cisplatin. Very interesting data, and I think it will be interesting to see what will happen with the regulatory fate of enfortumab in the second line space after immunotherapy. In addition, there is some very promising data in the frontline space in combination with Pembro plus enfortumab vedotin with the overall response rate 73%. In the EV103 phase 1b trial that is actually supporting an ongoing phase 3 trial called EV302, which is actually comparing pembrolizumab plus enfortumab vedotin combination compared to platinum-based chemotherapy, gemcitabine or gemcarbo. Very important trial, phase 3 EV302. The only caveat I would say for the chemotherapy control arm in the EV302 is that it lacks a switch maintenance therapy in the chemotherapy control, but overall very important trial.
Very good. Thanks so much. Dr. Agarwal, any final thoughts and any challenges with giving this on a weekly basis for your patients? Dr. Agarwal, we don't hear you. You're on mute.
Nope, absolutely no challenges at all. I think these drugs, sacituzumab including, so you just talked about enfortumab vedotin, but Dr. Grivas also mentioned sacituzumab govitecan, and I think all these drugs, antibody drug conjugates, which are much better tolerated, more patients are eligible to receive them, will allow more patients to transition to, first of all, receive first-line therapy, and then transition to second-line and third-line therapy. So overall, our patient population with metastatic bladder cancer are going to receive much better tolerated and more effective chemotherapies in the form of antibody drug conjugates in the next 3-4 years. It's starting now. Yeah.
I love that overview, really thinking about the unmet needs in the refractory space, and then as we go through, hopefully in the future, we're moving these agents in earlier space. Very good. I think we'll go ahead and move to the next abstract. The next one that we'll talk about is Checkmate 274, adjuvant nivolumab versus placebo in patients with high-risk muscle-invasive urothelial carcinoma. Dr. Gupta, do you want to start us off with the summary here?
Yes, absolutely. So this was a highly awaited study presented by Dr. Dean Bajoran's team on behalf of Checkmate 274. This is a phase 3 randomized double-blind trial of nivolumab versus placebo in patients with high-risk muscle-invasive urothelial cancer, including bladder as well as upper tract disease after radical surgery. As you know, there's no currently approved therapies apart from platinums in upper tract disease, which cannot be given to all the patients. This was around a 700 patient trial. Patients were randomized 1:1 to nivolumab or placebo for up to 1 year. Primary endpoint was disease-free survival in intention to treat population and PD-L1 positive subgroups. And this study showed, as we can see on this slide, that there was an improvement in the disease-free survival in the intention to treat population by 10 months with 10.9 months in the placebo group and 21 months in the nivolumab group. And in the PD-L1 positive population, it was even more pronounced. In my opinion, this data is very encouraging, especially after the recent IMvigor010 study, which looked at atezolizumab in a similar setting. Although the control arm was not with placebo, that study did not show any disease-free survival improvement either in intensive to treat or PD-L1 positive population. I would want to wait for the overall survival benefit to see how this pans out. And that's my take for it. Very encouraging data.
That's a great summary, Dr. Gupta. Thank you so much. I want to pivot here to Dr. Grivas. Can you tell us a bit about this trial design, any advantages, disadvantages here, looking at the intention to treat versus the PD-L1 positive populations, and what do you think about using nivolumab in this space?
Thank you so much. I think Dr. Gupta did a fantastic summary of the design of the study. I would add a couple of comments. Number one, there was a fundamental difference between this trial, the TECMEDO-74, and the IMvigor010. As discussed, this trial was a placebo-controlled trial here. The control arm of the IMvigor010 had an observation arm. And if you look at the IMvigor010 short diagram, I think there was a 10% dropout rate in the observation group. And this it actually can result in early censoring, which in my mind, make me wonder whether this early censoring in the IMvigor010 could potentially have made the control group of the IMvigor010 to actually appear worse. I'm sorry, I said opposite, to actually perform better. And when the control arm in IMvigor010 could have performed better, this could potentially wash out any difference compared to the atezolizumab arm. So this is one theory. Again, I don't know if it explains the different outcomes here and the results from the two studies with early censoring and potential, I would say, false interpretation of overperformance of the control group in IMvigor010. However, this is something to discuss. Having said that, there are people who believe, that placebo is very difficult, right? And patient advocates do not like placebo in randomized trials. I think it's a longer discussion, but it's actually a relevant point to this debate. I think, as Dr. Gupta said, there are definitely patient characteristics that can play a role, as well as the design. Overall, I think that there are different assays in PD-L1 that also can be relevant in the biomarker discussion. Overall, I would agree this is a very impressive disease-free survival differences. I would personally agree with Dr. Gupta. I would like to see overall survival data, whether to change my practice. The question is whether DFS is surrogate for overall survival. I do not think we know the answer yet, especially within the context of IO adjuvant therapy.
Very helpful. Maybe not yet for this disease space, for disease-free survival being a surrogate for overall survival. Very helpful. Dr. Agarwal, seemingly positive study based on the primary disease-free survival endpoint. Would you recommend adjuvant nivolumab for your patient who's just undergone a radical cystectomy? And is this practice changing for what you would do currently?
I do not have anything new to add. I agree with Dr. Gupta and Dr. Grivas. I'll wait for more data for now, especially given different results from IMvigor010 trial versus this trial. I think the next trial, which is going to break this equipoise, if you will be the ambassador trial. And that is interrogating the role of pembrolizumab in this setting. So I think I would wait for more data and the results from the ambassador trial.
Great, and to correlate with that, the ambassador trial, of course, is Dr. Apollo's study that's currently enrolling in the NCTN cooperative groups. And then we do also have a targeted adjuvant therapy trial called Proof 302 that's adjuvant infigratinib that's also enrolling for patients who have FGFR mutations and other alterations. And so certainly, at least at Duke, I have both of those trials open, and if a patient came in next week, we could consider them for either of those studies. So that's really helpful in terms of placing it in context of the ongoing studies that patients are eligible for, and think about what other studies are available for these patients. You know, in terms of nivolumab, though, being the treatment here, though, you know, Dr. Gupta, we know nivolumab pretty well now in multiple disease contexts. Do you see any challenges with using nivolumab? If and when we do change our treatment patterns, are there any difficulties with obtaining nivolumab for this patient population?
No, I don't have any safety concerns. The tolerability and safety profile was as expected from this study. The only thing I will add is that in the secondary endpoints in the non-urothelial recurrence-free survival and distant metastases-free survival, the curves start to overlap over time. And that's why I think it would be really good to see what the long-term data suggests. But so far, this is a great beginning of adjuvant immunotherapy promise.
Great. You know, as we were listening to the chatter after this abstract was presented yesterday, a lot of people brought up the point of thinking about molecular testing with circulating tumor DNA in the setting, and whether that can inform our practices and other studies. So Dr. Grivas, can you tell us a little bit more about the role of circulating tumor DNA and what that might have for us to find these patients who might recur earlier?
Absolutely, this is a great point, and I think that there's very interesting data from an exploratory analysis from the IMvigor010. We discussed before about that study, and the interesting data shows that in the subset of patients with circulating DNA positive biomarker that may be representing an enriched population with higher number of events, worse prognosis, higher recurrence rate, in this subset of ctDNA positive patients, atezolizumab prolonged overall survival compared to observation in the IMvigor010 trial. And this actually has supported the launching of a new phase 3 trial in ctDNA positive patients, the IMvigor011, which I think is very interesting. And ctDNA, at least based on that particular assay that they used in that study, might represent a biomarker to enrich patients with higher risk of recurrence. So I'm very excited to see the results in print of the exploratory analysis of the IMvigor010, as well as in the future, the 011 phase 3 trial in those patients.
That's really helpful. I do want to take a moment at this point, you know, with adjuvant in your patients who undergo cystectomy and say either have nodal positive disease at the time or you know, T3, T4 disease, you know, molecular testing, you know, circulating tumor DNA aside, any other molecular features that you guys are consistently testing over for this patient population, and what's your practice pattern there? Dr. Agarwal, what are you doing for your patients when they come to you post-op?
At this time, I continue. We have proof trial open at the Huntsman Cancer Institute. So infigratinib for patients who have qualifying mutations. And I continue to favor clinical trials in this setting.
Wonderful. No, that's very, very helpful. So I think everybody on the call here is thinking still to enroll their patients in the ongoing trials, Ambassador and Proof 302. Dr. Gupta, we'll circle back with you. Any concluding thoughts for this abstract?
No, I think this is a great data, and Ambassador trial will provide further insight into where we stand with immunotherapies. But at our institution also, we are enrolling patients on the Proof 302 whenever possible.
Great. No, that's wonderful to hear. All right. With that, I think we'll move on to our fourth abstract. This is the CLEAR trial, which was presented today by Dr. Motzer in the renal cell oral session. This is phase 3 trial of lenvatinib with pembrolizumab or everolimus versus sunitinib as first-line treatment for metastatic renal cell carcinoma. Dr. Agarwal, we'll come back to you. Can you give us a quick summary of this study?
Yes. So CLEAR trial was a really large trial comparing 3 different agents or combinations, if you will. Sunitinib, one arm, lenvatinib with pembrolizumab, one arm, lenvatinib with everolimus in one arm. So lenvatinib with everolimus is a regimen is already approved for salvage therapy setting in metastatic clear cell RCC. The primary endpoint was like progression-free survival, and there were multiple secondary endpoints. The most important was overall survival. And what we saw was the most very remarkable improvement, not surprising, by the way. We are seeing this theme with multiple trials back to back. This was another trial combining a potent TKI with a checkpoint inhibitor, which is pembrolizumab in this case. Lenvatinib was a TKI. And this is the theme we have seen with cabozantinib with nivolumab. Prior to that, we have seen with axitinib with pembrolizumab. So what we saw was a remarkable improvement in progression-free survival, which was 23.9 months with the combination versus 9.2 months with sunitinib, with a hazard ratio of 3.39. So the most remarkable hazard ratio we have seen so far. Overall survival is also higher significantly, with a hazard ratio of 0.66, which is basically approximately 34%, 35% reduction in risk of death with this regimen. I would like to highlight one aspect of this trial, which is this trial has the lowest number of poor risk patients included in all contemporary trials, So if you look at the poor risk patients in this trial, 9% compared to, say, cabozantinib nivolumab 9ER trial, we were close to 20% patients. Axitinib pembrolizumab trial, again, very similar number of patients. So this is a difference in this trial. So we are seeing improvement in progression-free survival with a very impressive PFS hazard ratio, improvement in overall survival, and just talking about the combination of lenvatinib everolimus to see, because this was another arm, it is definitely improved. It is showing improvement in progression-free survival at 15 months, exactly similar to what it showed in the original trial leading to approval of lenvatinib everolimus, 15-month PFS compared to sunitinib of 9 months, but there was no overall survival benefit with the lenvatinib everolimus combination. So just putting together, and I do like to throw in the toxicity data here. If you look at the grade 3-4 toxicity, we are looking at 10% increase in grade 3-4 toxicity with the combination of lenvatinib with everolimus versus sunitinib. So higher toxicity, not that high, but higher, not unexpected completely. And this is what we have. So a combination which has a very promising responses, progression-free survival benefit we have not seen to date, is slightly more toxic, if you will, and is also associated with overall survival. That's my synopsis of the data.
That's perfect. Thank you so much for taking us through a complicated 3-arm study that certainly is impacting our first-line treatments, and it really cements this practice pattern of VEGF-IO combinations in this frontline setting. Dr. Grivas, can you talk to us a little bit, because there's been a lot of discussion about when do we do an overall survival cutoff, and how does this impact what we're seeing after, for this, the median overall survival, median follow-up was about 26 months. So how does that impact what we're seeing after that time point for this particular study cutoff and data that we're seeing today?
Thank you so much. A great summary by Dr. Agarwal, in a very important trial, definitely informed clinical practice, adds another option in the embarrassment of riches, as I call it, the plethora of options in the frontline setting of metastatic clear cell RCC. I think your point is very good regarding the median follow-up and how you interpret Kaplan-Meier curves. If you focus your attention in the latter part, of this curve, the estimate, especially, approaching 2.5 to 3 years out, you see that in the lower part of this x-axis, you see very low numbers, which means that your estimate, because Kaplan-Meier curve is also an estimate of what is the outcome, the endpoint. You see very low numbers. So this, I think, makes this estimate a little bit unstable. That's why it's hard to interpret, why these curves are coming together actually, exactly at about, 33 months or so. And the question I have is whether with longer follow-up, we'll have a little bit more granularity, what happens in the long term. And I think it's too early to call, talk about a 3-year, landmark overall survival rate, which can be relevant, especially as we see subsequent therapies and patients may live longer. But I think the follow-up duration is important, how we can interpret the data. But definitely to me, it makes me really want to see what happens with longer follow-up and why these curves are coming together, especially when we approach 2.5 years. Another quick comment I would make is patient selection and baseline characteristics, to your point, are very important. And I think that can potentially explain some differences across different trials in the frontline setting, proportion of patients with favorable disease group risk, patients with prior nephrectomy, and I think all these factors could play a role. But if anything, the concept of VEGF-TKI plus checkpoint inhibitor seems to provide compelling data with, again, among different subgroups, especially the intermediate and poor risk. We see consistent signal. In the favorable risk group, this trial did not show that impressive result, which again makes us wonder why that's the case. But the number of events is definitely lower in the favorable risk group. So interesting point, and always important again to look at the sample size, duration of follow-up, and the different selection of patients.
Yeah, no, that's really helpful points to point out. So favorable risk was about 31%, if I remember correctly. Poor risk disease, as Dr. Agarwal pointed out, was right around 9%. And the prior nephrectomy rate was right around 3/4, 74, 75%. So certainly those might impact what we're seeing for all of these clinically relevant endpoints in terms of picking the treatment selection for the right cohort of patients. Dr. Gupta, I want to turn to you for a moment and talk a little bit about the challenges of prescribing and giving this combination. Of note, the starting dose here for lenvatinib was at 20 milligrams, which is a little bit different than the starting dose in our current lenvatinib everolimus combination of 18 milligram. Can you comment a little bit about that and what challenges there might be in terms of accessing this combination for your patients?
Yeah, I would congratulate Dr. Agarwal and Dr. Grivas for their thoughts on this. I think, we are at a point where we have multiple IO-TKI regimens with mostly similar efficacy, and then the bottom line comes down to tolerability. Now, this regimen, I think over 70% patients with grade 3 AEs, it's a little concerning, and the dose of lenvatinib is higher than what we are used to. And majority of patients did require dose reductions. I would have to see what in the real world, how well patients tolerate this dose. But I would also like to point out here that we have to be cognizant of what to do after patients progress on first-line IO-TKI. When we are using such very potent regimens up front, that really leaves little room for what to do if the patients progress on this. On the other hand, a regimen like axitinib and pembrolizumab, we know that when the patients progress, you have the option of using lenvatinib or cabozantinib or lenvatinib and everolimus. So I think it's all about the toxicity. I was a little concerned with the safety profile of this dose, and would like to see more follow-up data.
That's a great summary, Dr. Gupta, and certainly from toxicity standpoint, depends on how people will tolerate. I think the majority of patients actually had to dose reduce on the lenvatinib, so it's good to know it certainly still has activity despite dose reduction, but certainly something to keep an eye on for all of our patients. And I loved your point, very insightful about sequencing treatments, especially, our patients with metastatic kidney cancer often are dealing with a longitudinal disease course, and they're going to see multiple lines of treatment and hopefully have multiple options available to them. So Dr. Agarwal, in terms of thinking about sequencing and how you might recommend treatments for your next patients coming to you in clinic, what are your thoughts there? How are you going to select the right patients for frontline therapy, and who might you particularly think about lenvatinib pembrolizumab for?
So first of all, for majority of my patients with metastatic RCC, and obviously I'm talking about intermediate poor risk patient group, not favorable risk category right now, I use ipilimumab nivolumab combination. So IO combination, mainly because first of all, we have never seen 48-month median overall survival with any combination to date. There was a very elegant editorial by Dr. Raboud from France on this paper which got published in New England Journal of Medicine today. And he highlighted the fact that no other regimen has this long overall survival shown yet. Number two is the responses, complete responses and objective responses, they are durable with ipilimumab nivolumab. We do not know that with VEGF TKI IO combinations. So my preferred regimen remains ipilimumab nivolumab because of the durable complete responses and partial responses. Second thing, where I will use these combinations of TKI IOs, I think patients who have, if you look at primary progressive disease rates, they are very low with cabozantinib nivolumab combination or lenvatinib pembrolizumab combination. So primary progressive disease rates, so in those patients who have rapidly progressive high volume disease, I think I'm using these IO TKI combination right now, small number of patients, but I will continue to use them. Now, how to pick up one of these two regimens? I think these PFS hazard ratio of 0.5 for cabozantinib nivolumab or 0.4, if you will, for lenvatinib pembrolizumab are very similar in my view. The advantage of cabozantinib nivolumab currently, there is advantage, which is the huge improvement in quality of life with cabozantinib nivolumab. So I think if I am using, so first of all, I'm using ipilimumab nivolumab for most of my patients. But if I'm using a TKI IO combination, I think I would continue to prefer cabozantinib nivolumab so far, so until we have quality of life data from the CLEAR trial. And last comment on sequencing, the lenvatinib everolimus combination is the only combination regimen which is effective after patients have disease progression on cabozantinib based regimen. I have used cabozantinib for a really long time since the trial, Meteor trial days. And in my view, the only regimen which works after cabozantinib has failed our patients is lenvatinib everolimus combination. So that's another reason for me to keep lenvatinib as a more salvage therapy combination in a salvage therapy setting.
That's super helpful in terms of thinking about sequencing and the agents available to us. Dr. Grivas, do you want to chime in here about kind of the frontline space and what you might do for your patients coming into clinic for you?
I think this has been a great discussion with Dr. Agarwal, Dr. Gupta's comment here. I think great points were made. It's a totality of the data approach. And I think when you make a decision in clinical practice, you look at efficacy, overall survival, PFS, overall response rate across different groups of patients. And I think the IMDC criteria are relevant. Again, in favorable risk patients, I think cabo-nivo or pembro-axi are probably my go-to options in the favorable risk group. In intermediate poor risk group, I think you have options. I think there are individualized scenarios. For example, patients with very significant hard to control hypertension or recent massive PE or thromboembolic disease, you might shy away from a VEGF TKI and may use ipi-nivo. In patients with brain mets, treated may use ipi-nivo. However, I think most patients, even at least in my mind, intermediate poor risk, are probably going to get VEGF TKI IO if you want to control the disease early, have like a rapid high response rate. But to Neeraj's point, longer term, you see definitely great data with ipi-nivo. So I don't think there is a clear answer. The NCTN, National Clinical Trial Network, is planning a randomized phase 3 trial comparing the immunotherapy combo versus VEGF-TKI IO. And I think it's important to enroll in trials. And talking about trials, I want to also emphasize your trial, Dr. Zhang, the Pedigree trial, which I think is very important, another cooperative group study coming from Alliance with you, Dr. Choi, Dr. George. And I think it's important because it's going to answer some important questions. I think in this context of multiple different options, clinical trials is still a great option. And I want to make this point loud and clear.
Sure. No, thank you for mentioning Pedigree, and certainly it allows us to answer hopefully some sequencing questions of ipi-nivo followed by nivo-cabo versus nivo alone. And also some important questions around treatment discontinuation as well for complete responders. Dr. Agarwal, we'll circle back and any concluding thoughts for us about the CLEAR trial and the lenvatinib pembrolizumab combination.
So interestingly, when the press release came out, one of my community oncology colleagues asked me, what should I do? What do you think I should do? And those are very smart people. They're seeing patients with 100 different cancer types, as opposed to us. We are specializing in 2 or 3 cancers at the most. And he basically asked me a very simple question. I'm using axitinib pembrolizumab right now. Give me a compelling reason why I should abandon that regimen. And I could not answer his question because there's not been a head-to-head comparison trial comparing these regimens with newer regimens. And community-based patients may be more frail. We all know that patients who are able to make it to large cancer centers, who can travel 2 or 3 hours or take a flight to go to these cancer centers, they are healthier. They are more, they're better physical shape. So I think it is going to be more and more challenging for most of us who are not specializing in treatment of metastatic RCC in picking up the right combination, ideal combination. And that's where the biomarker will play a role, biomarkers. So I think it is high time now that we focus on resources to develop biomarkers in the real world setting. And I think your colleague, Dr. Dan George at the Duke University, has taken up a fantastic initiative of comparing the efficacy and toxicity along with biomarkers, along with interrogating and validating biomarkers in the real world setting. And I think, those kind of studies, real world setting, where patients are being followed, where blood samples are being collected, and their efficacy and toxicity are being prospectively measured. I think those are the studies which are going to answer these questions ultimately.
That's a great conclusion, and it really does highlight, the need for, clinical trial populations aside, how our real world practice, the patients who are coming to us who are not trial candidates, how those patients will do, and hope Odyssey will certainly help us inform future practices. Great, wonderful. I'd like to move on for purposes of time, but wonderful discussion. And if we haven't already, actually, I do want to state that CLEAR was published in the New England Journal, and full updates there to cement this VEGF-IO combination in this frontline setting. Excellent. All right. And then now, Kanisha, if you can go to the next slide, please. So for our final abstract that we'll highlight tonight, I have the honor and privilege of discussing the SWOG 1500 trial presented by Dr. Pal earlier today of sunitinib versus cabozantinib, crizotinib, or savolitinib in metastatic papillary renal cell carcinoma, the phase 2 SWOG 1500 study. And certainly in non-clear cell kidney cancers, it's very difficult to do studies, and papillary renal cell carcinoma makes up for about 15% of all kidney cancers that we diagnose. And so this was a cooperative group setting in which we were able to enroll all of these patients with the papillary renal cell carcinoma, and specifically a trial dedicated to papillary renal cell carcinoma. So kudos to Dr. Powell for doing this. The sunitinib was the prior standard of care for these patients based on the historical ASPEN and ESPN studies. And so this study was initially designed as a 4-cohort study with the control cohort being that standard of care with sunitinib. But patients with metastatic papillary renal cell carcinoma were enrolled and essentially as randomized to one of 4 treatment cohorts: sunitinib, cabozantinib, crizotinib, and savolitinib. Crizotinib and savolitinib were chosen because of the MET-driven nature of papillary kidney cancers, and so these are more MET-specific inhibitors. Unfortunately, at the interim analysis, the savolitinib and crizotinib cohorts did not show enough efficacy, and so at the interim analysis, those cohorts were closed, and the study completed enrollment in the sunitinib and cabozantinib cohorts. High-level data-wise, cabozantinib improved progression-free survival, which was the primary endpoint here, compared to sunitinib. Median PFS we saw today was 9 months for cabozantinib versus 5.6 months for sunitinib, and also overall survival was 20 months for cabozantinib and 16.4 months for sunitinib. We also saw an improved overall response rate, about 23% for cabozantinib compared to only 4% for sunitinib. And so with all of these efficacy endpoints, we saw good disease activity for cabozantinib. And so this was concurrently published today in the Lancet by Dr. Paul and colleagues across the cooperative groups, and certainly represents a change in our standard of care treatment options for these patients with papillary renal cell carcinoma. So with that summary, I'd love to turn our attention and pivot to Dr. Grivas. Any challenges here with the trial design or anything that you're seeing pop out at you just from kind of high-level approach of this study?
I agree with your excellent summary. I think kudos goes to Dr. Pal and the cooperative group. SWOG 1500 has been a very important trial. If you think about trial design, you have to take into account context, and context is that we deal with a relatively uncommon disease. So it's not your classical clear cell RCC where you have tons of patients, you can do big randomized phase 3 trials without problems. I think it's an inherent challenge, limitation to make huge trials in an uncommon disease, and cooperative groups can take this on. So I think the design was actually, in my opinion, very good. It was a positive design and good idea. The approach included initially 4 agents to try to see if there is any discernible signals. And early on, 2 of those drugs were dropped, and then it ended up being a, kind of randomized trial, reminding me the CABOSUN trial in clear cell RCC by Dr. Chueri, and it reminded me that. I think the selection of the primary endpoint of PFS is clinically relevant, and in this context of this study, and I think that overall, despite not showing overall survival, which is very hard with a low sample size and low number of events, I think this particular trial, based on overall response rate and PFS data, in my humble opinion, I think it can inform practice, and cabozantinib can be a very reasonable option in patients with papillary metastatic RCC. There's a lot of discussion about the different histology, parameters. There was, type 1 versus type 2 version classified. I think it's a very positive thing that they had a central pathology review and they try to have a consensus of how to classify papillary RCC. I'm looking forward to more biomarker data down the road based on the work that Dr. Brian Tsai and others can do. And I think overall, again, very important unmet need. Congratulations to you, Tian. You were part of the study. Dr. Pal and everybody, I think this is relevant to practice.
Thank you so much. Certainly changing what we can do for our patients with papillary renal cell carcinoma. Pivoting to Dr. Agarwal, what are your thoughts about challenges in prescribing cabozantinib for patients with papillary kidney cancer?
So I'll take a step back and basically reiterate what I've been wanting to for last 5 minutes, ever since you gave the mic to Dr. Grivas first. This trial establishes cabozantinib as the standard of care for patients with papillary type metastatic renal cell carcinoma. It is hard to imagine until today, we have not had any drug trial which was randomized and which was positive conducted in this setting. So for these 15% patients of total who are diagnosed to have metastatic kidney cancer, 15% of them have papillary type renal cell carcinoma. Cabozantinib is the standard of care, and newer combinations or newer regimens will have to be either developed on this platform or will be compared with this cabozantinib, the new standard of care. Regarding how will I use it, I think cabozantinib is already there in the clinic for last, I think if I'm correct, 5 years at least. I think we all have very good experience of using cabozantinib. Even my community colleagues are using cabozantinib. I think this is one of the most potent VEGF TKI as a monotherapy in kidney cancer. I don't think anything comes close as far as monotherapy efficacy data of cabozantinib is concerned from the METEOR trial. So I think this is all great news for our patients with metastatic RCC, specifically for metastatic papillary type RCC.
That's perfect. Thank you so much for being very clear about how cabozantinib is established as standard of care. I fully agree with you.
And kudos to Dr. Monty Paul. I cannot, thank him enough to even imagine this trial. Kudos to him for bringing 4 drugs together. When was the last time you saw a trial where we got 4 drugs from 4 different companies and compared them in one trial? This is the future. I think this is how trials should be done.
I hope so, and so we can find the winner. Very good. Dr. Gupta, does this, we'd love to hear from you in terms of how this will change your practice and change what you do for your next patient with papillary renal cell.
I would completely echo Dr. Agarwal's and Dr. Grivas' comments. In the clinic, we are using cabozantinib already, and this just seals the deal, in my opinion. Like Neeraj said, this is the first prospective trial to show superiority of cabozantinib over the traditional TKI sunitinib in papillary RCC. And we are very familiar with the agent, have no toxicity concerns. We are very well aware of how to modify the doses. I think this is the new standard of care, and a cooperative group will further build upon these platforms, I'm sure, with combining with immunotherapy. And Dr. Agarwal can comment on this with Dr. and Dr. Paul, I think, already talking about adding immunotherapy to cabozantinib, and that's the future. So very excited.
Future is potentially to build on cabo as the backbone. Very good. So I'd love to just take the last 2 minutes, and if we can all go around and give a 30-second sort of highlights of GU ASCO themes and what you took away. And I'd love to start with Dr. Gupta.
I think this was a very exciting GU ASCO. For me, we saw for the first time a positive study in adjuvant urothelial cancer, CheckMate 274. We saw confirmatory trial with enfortumab vedotin in refractory urothelial cancer, and several other newer therapies, and kidney cancer with the PAPMET trial, and the CLEAR trial was very exciting data.
Very good. Dr. Grivas, give us your overview and what you found exciting.
Fantastic ASCO GU. I think we saw very interesting data across tumor types. We don't talk a lot about testis cancer, but there were some interesting presentations there too. I think we covered the highlights here in terms of practice implications in kidney cancer, the CLEAR trial with pembrolizumab, the PAPMET trial by Dr. Pal, that introduced a new standard of care of cabo in papillary RCC, and also what we discussed in urothelial cancer, with enfortumab vedotin being now the standard of care in the third-line setting. I think we, as we discussed, need more data in the adjuvant trials, and I echo the comments about accrual in trials across the board, like the PROOF 302, Ambassador, and other studies. And I think there is a lot of discussion about genomic profiling of patients. When do you do genomic testing? And I think that's a relevant discussion. I foresee the future utilizing more both germline and somatic mutation testing. and I also see potential for immunotherapy combinations that are being tested, also in urothelial cancer. Overall, exciting studies we saw, and I'm hopeful for the future for more treatments and also more biomarker data.
That's wonderful. Great summary. Dr. Agarwal, your highlights and conclusions.
I'll just add, instead of repeating what we have already done in an outstanding fashion by Dr. Grivas, Dr. Gupta, and yourself. So I'd just like to talk about two prostate findings or two prostate abstracts. One was the Titan trial, which I had the privilege to be involved in, and updated survival data, adjusting for crossover. Hazard ratio is almost like 50% reduction in risk of death with upfront use of apalutamide. I don't think we have seen this kind of survival benefit with any drug in metastatic castration-sensitive prostate cancer yet. I'm sure more things will happen down the line. More analysis will be done about current trials. But this is very remarkable, and coupled with the fact that minority of patients in the US are being treated with upfront intensification. So we'll be showing the data in ASCO meeting that vast majority of patients in the US are still being treated with standard androgen deprivation therapy, regardless of insurance status, regardless of where they live, regardless of how much they can afford, or how frail or robust they are. So I think given these data, it is not acceptable anymore to treat our patients with standard androgen deprivation therapy. And another one is the circulating tumor DNA from two different abstracts from Gardrint and Foundation Medicine, both companies which are the front runners in circulating tumor DNA analysis, showed that it is absolutely feasible, practical, and productive to use circulating tumor DNA from the patients with metastatic prostate cancer who are very difficult to biopsy because of the bone metastasis, predominance of bone metastasis in these patients. So circulating tumor DNA is a very good source or good avenue for detecting homologous recombination repair mutation in these patients. So let's not miss any of those patients from being candidates for treatment with PARP inhibitors, which are new class of drug in the clinic now. So just wanted to make sure I highlight those two abstracts of findings in prostate cancer.
And congrats, Dr. Agarwal, for great work in the Titan study.
That's right. So great. I'd love to give you just my 2 cents. I appreciate the circle back to prostate cancer, Dr. Agarwal. I was going to also add, we're really seeing molecular determinants and biomarkers to help us select treatments, especially with the PARP inhibitors being most recently approved to help us find those patients who might benefit from PARPs. And really, we saw some interesting things about molecular imaging too, right? The PSMA PETs, and hopefully laying the landscape for future PSMA targeted treatment options as well. So certainly a lot of exciting things. And in bladder cancer, I thought this was very exciting for enfortumab vedotin and other antibody drug conjugates in refractory disease, and hopefully we'll start to see them moved forward in the earlier disease settings. And then, I haven't seen a GU ASCO with 2 New England Journal papers and a Lancet paper all concurrently published. So certainly very, very exciting data and trials that changes our practice in kidney cancer as well. So we are so excited about this data. We went 5 minutes over time because we had so much to discuss, but we appreciate everybody who joined us today, and hopefully to quote Tony Schwery, next year in San Francisco, and hopefully you all stay safe and healthy. Take care.
Thank you.
Thank you. Bye-bye.
Thank you so much,
Thank
everyone.
you.
Bye, everyone.
Bye. Thank you so much.